That to conclude the session.
Yeah, sure. Yeah, may I request now, Chairperson, sir? For the closure of this program. Or in case I can also request Nishita ma'am, are you there? Nishita from ClearNet, are you there? We can all ask ourselves to just switch on the video for a minute and take a brief snap of this wonderful session. Everybody can switch on the video just for a minute, and with this, then we can close the session. Nishita ma'am, are you there? Okay, so with this, we come to the end of the session.
Okay, thank you, Dr. Nilanjana Ghosh, for the wonderful moderation. Thank you to all the speakers for their insightful discussions, and thank you to the chairperson for making your time for chairing the session. Now I am handing over the session to Dr. Shatabdi Mitra for our last session of this conference. Shatabdi, please.
Thank you. Thank you.
Very good afternoon to everybody. Dr. Ms. Ishita, please allow Dr. Nirmal Mondal sir to be the panelist. Probably sir is here, but sir has joined as only attendee. Sir is asking for that.
Nishita, please, Nirmal sir has raised his hands. Please allow him as a panelist. Okay, they are doing that. Is Dr. Konika Mitra here?
No, ma'am. Just now, ma'am, talk to me. She is joining.
Okay, okay.
Actually, she was asked to join by 16:30, and so she is having a meeting, and she told that as it is hit of time, she will join. She is probably please check Dr. Rebu sir, has she joined or not? She told that she has joined now. Let me check once from another. Ma'am has not joined, na? Call me, ma'am. Okay, madam is joining.
Okay, thank you. Nirmal sir is already here. So
yes,
Nirmal sir can introduce the session meanwhile. Okay. Your screen is visible.
Yes, thank you.
Madam has joined. Okay.
Okay. A very good afternoon and welcome to all the attendees, Chairperson, Professor Dr. Nirmal Kumar Mandal. I am extremely sorry to have mistaken name of sir's name spelling. And our today's speaker, Dr. Kaninika Mitra. Professor Dr. Nirmal Kumar Mandal is currently working as professor and head of the Department of Community Medicine, Diamond Harbour Government Medical College and Hospital. He is MBBS from Nilotan Sharkar Medical College and has done his MD from prestigious All India Institute of Hygiene and Public Health. Sir has worked as medical officer under the West Bengal Health Services for 11 years. He has worked as the faculty member of community medicine in different medical colleges of West Bengal for last 21 years. And Sir was the Dean of Students Affairs in Malda Medical College. Sir is the examiner, convener, and paper setter of undergraduate courses and adjudicator of theses of post-graduation courses. Sir has acted as chairperson of different scientific seminars of state and national conferences of Indian Public Health Association and IAPSM. He has published more than 30 scientific papers in different state, national, and international journals. And Sir now is bearing the huge responsibility of editor of Journal of Comprehensive Health. Now I'm going to introduce our today's speaker, Dr. Kaninika Mitra Madam. Dr. Kaninika Mitra is MBBS MD DCH. She can be easily called as a lioness figure and public health specialist working with UNICEF. She is renowned public health professional working in the field of maternal and child health for more than 25 years, of which about 25 years she is working with UNICEF. Dr. Kaninika Mitra is a medical graduate of Kolkata Medical College and has done her post-graduation from All India Institute of Public Health, Institute of Hygiene and Public Health and ICH of Kolkata. She started her professional career in rural hospital, South 24 Parganas, West Bengal, and later she worked as faculty member of community medicine and also as at the state secretariat as a technical officer. In UNICEF, Madam is working in health, HIV and nutrition sector. I'm now taking the permission and asking Professor Nirmal Mandal sir to continue and the session. Thank you.
Thank you, Shatabdi. Hello.
Yes,
Hello?
yes, sir.
Very good afternoon to all. We are at the end of our today's conference, and I really feel very happy and that our organizer has given me the opportunity to chair the session. So as we know that National Family Health Survey, it has been emerged as nationally important data source on population health and nutrition. NFHS-5, as its name suggests, that is the fifth of this series. The first started in 1992-93 time framework, and now the fifth, it is in 2019-21 time framework. It has generated high quality of data, which is useful to examine progress of health sector over time. It will also provide evidences for effectiveness of ongoing program, and also will help identifying the need of improved policy decision and plan strategies for intervention at national, state, and district levels. This time, several new emerging issues have been incorporated in this survey, which include preschool education, disability, access to toilet facilities, death registration, menstrual hygiene, method and reasons of the abortion, and some anthropometric and biochemical tests also incorporated in this survey, including blood pressure and random blood sugar. So it will be a very fruitful discussion. So far as our speaker is concerned, Dr. Kaninika Mitra, she is not only the health specialist of UNICEF, but she is very closely associated with us. She has been closely associated with IAPSM for a long time. And not only that, we do not think conference of IAPSM West Bengal chapter without her participation. So it is my great privilege to invite Dr. Mitro. Please speak on these important topics and enlighten us. Dr. Mitro, please.
Namaskar, good evening, Nirmal and everyone, the rest who are here today. So it's also my privilege to be invited by IAPSM. And NFHS-5 has been released and more or less everybody knows everything. So it's not that I'm going to tell you something which is new, and it would have been much better if we could have, had a face-to-face conversation, because there are certain things which NFHS-5 has, brought up, which if we go in depth, we are not very sure the reasons of why this kind of data has come up. So that's why it would have been much better if we could have had, and maybe later we can have a few people, we can sit across the table and discuss that what are the reasons and what can be the way forward. And I'm sure IAPSM also in its own way can also dig deeper into some of the issues that have been brought up by NFHS-5. So since we know more or less everything, today what I would be talking about are about the areas of concern. I mean, we know what are the things more or less which have improved. Many things have improved, but areas of concern, and going a little deeper into the areas of concern. So can you see my slides? Can you see my slides?
No, ma'am, it's not. Yes, ma'am, coming.
Okay. So these are and I would be mostly focusing on West Bengal. And as you know that the West Bengal NFHS-5 data was released in the first round, and recently the national data has also been released. And some big states were not taken in the data was not released in the first round, which was UP, MP, etc. But now we have the data for all the states, as well as for the fact sheet for national fact sheet is also out. And for West Bengal, not only the fact sheet, but also the report is out. So we have some disaggregated data with us. And at the same time, we have also seen the SRS 2019 bulletin has been released recently. And we know that at least for the mortality data, we depend more on the SRS than on the NFHS. So here I will not be delving deep into the mortality data that has been brought out by NFHS, but I would be talking about the other data that has been, because we know for mortality data, SRS is more reliable. And as I said, overall reduction in child infant neonatal mortality in NFHS as well as SRS, which has given the infant mortality, it does not give the child and neonatal in the bulletins. It gives it only in the reports, which are released from time to time. And NFHS-5 has also shown improvement in coverage of many service delivery indicators. Most of the service delivery indicators in West Bengal have improved. Service delivery indicators, mind you. However, there are areas of concern which are mostly related to behavior, family level behavior, individual behavior, community level behavior, and social norms. And of course, inequity has been highlighted, has been revealed. It was there, which is still there, and maybe it's increasing. And to some extent, the quality of services, though NFHS does not go very deep into quality of services, but indirectly we can find out certain gaps in quality of services. So this presentation tries to capture these areas of concern. I will not go into the improvement areas in detail, but some will of course come in. So if you just look at this is just a glimpse of the RMNCHA. If we go by the life cycle approach or the continuum of care approach, you see the lower part, you can see the NFHS-4, and the upper part is the NFHS-5. So if we look at the ANC, first trimester 4 ANC, neonatal tetanus, that means tetanus toxoid, skilled health personnel conducting delivery, postnatal care for mothers, children, early initiation of breastfeeding, exclusive breastfeeding, intervalent full immunization, vitamin A and ORS. If you see, more or less, there has been improvement in all the areas, excepting a few like exclusive breastfeeding or a little bit in maybe in for ANC. But more or less, there has been improvement in across the continuum of care, pregnancy, birth, postnatal, infancy, and childhood. But when we go now, I mean, so I've just given you the glimpse, but now I go into the areas of concern. First is, of course, child marriage. This is something where I was saying that we have not yet fully understood what is happening in West Bengal. As you can see, there has been absolutely no reduction in child marriage in the last 5 years. No reduction. 41.6 remains 41.6, and it is much more than the India average, which is 23.3. I mean, almost more than 4. And of course, in urban and rural, there's a gap, definite gap, 26 and 48, almost double. And this is something which everybody is grappling with. We know there have been schemes like Konyashri schemes. However, there has been no reduction in child marriage in last 5 years. And wherever we are going, starting from the chief secretary to coming down to the ANM, we are having this same conversation that why it has not reduced even a bit. And of course, poverty, when we dig deeper into this, we know that poverty is the main underpinning thing, which is reason here. Social norms, yes, of course, social norm is very important, but the things, how it pans out in states like Rajasthan or Jharkhand, those are not similar as in West Bengal. In West Bengal, the issues are much complex, and it's like, it's not only the social norms that traditionally you have to get the girls married early. No, it's poverty. A lot of it is related to the security issue, security of girls. A lot of it is related to non-availability of any options, especially income generation, employability options. Men going out, dropping out of, boys going out, dropping out of schools, coming back with some money, and then they're marrying the girls who are attracted, maybe because they don't have any other alternative. The schools are not attractive enough because the teaching, the quality of teaching and the usefulness of that studies, with whether it can, it does not address the, or it does not transition to employability. So these are very complex issues, the sexuality issues which are not talked about. There's huge elopement, huge trafficking. I mean, in the name of marrying, there's trafficking. So this is a very complex issue, but we have not yet understood fully. And for this, the action has to be multi-sectoral. So just wanted to say that this is something which is a very, very important area in which impinges on women's health, because it leads to teenage pregnancy. As you can see, there has been slight reduction from 18.3 to 16.4, which is a 2 percentage point reduction. And nationally also the reduction has not been much, but nationally they are much lower than us. It's about 1/3 of what we have, 16 and 6.8. So when we look at it, we see that the main difference is made by schooling and not schooling, and urban rural, of course, there's a difference. Very, I mean, to break the myth, there's not much difference between Hindus and Muslims, must point that out, or in the castes, different castes, etc. So with a state which has a total fertility rate of 1.6, very high teenage pregnancy. So it's a real perplexing thing which is happening. Of course, it's because there's high child marriage. And if we see that it is, if we take 17 years, up to 17 years, it's 15%, then it jumps to 24%, 18 years, and 19 years, it jumps to 37%. So child marriage is entrenched in social norms, as we said, and it's very difficult to eliminate. But if we try, I mean, all the sectors try together, they think through and make the strategies by reaching every teenage couple and their families with contraceptives and counseling, this is something which is doable. Child marriage is very difficult to reduce, but teenage pregnancy, that means delaying the first childbirth after marriage, and mostly these are within marriage. Yes, there can be some which are outside marriage, but mostly it's contributed by married women, married couples. And in West Bengal, the peculiarity is the entry into education sector, I mean, in schools is very high. But then the dropout starts, and the dropouts first is of boys. Initially, the dropout of boys is very high, but then the dropout of girls happen. So, I mean, the boys, they go out for migration, for job. The girls, they do not have the flexibility or the freedom to go out for work, so they get married. I mean, that's what is happening, and they are bearing children, and this has an immense effect on the entire RMNCHA gamut. This is something, so child marriage and teenage pregnancy are the first area of concern that we should all be very, very, not only we should be thinking very seriously, and it's not only health sector which should be thinking seriously. There are many other sectors which should also join hands. Family planning, as we know, we have, as I said, very good TFR. Our unmet need is around 7%. But if you look at the family planning a little deeper, then you will see it's mostly only the female women who are taking the entire burden. And this is not changing over the years. Over the years, it's the same. 60.7% using modern methods. And if you look at what are the methods, female sterilization, basically it's female sterilization and pills. Condom a little bit, that's it. Apart from 7% being contributed by men, the entire thing is borne by the women. So 1/3 of men, and they think 1/3 of men think that contraception is actually women's business and man should not have worry about it. 15% think that women using contraception may become promiscuous also. And 53% of men knew that a condom, if used correctly, protects against pregnancy most of the time, but only 7%, as you see, are using it. And then there's not much difference between the contribution of female sterilization, but of course, if there's no schooling, she is more, I will have to take it because she has to control her own fertility, because she knows that there's more chance, if there's no less education, there's more chance of bearing more children. So they get married early, they have children early, and they have sterilization also early after maybe 2 children. And in Hindu and Muslim, there is some difference because female sterilization is less in Muslims than in Hindu, but not much difference in schedule caste, schedule tribe, etc. And rural areas, of course, sterilization is more. Coming to the antenatal care, you will see it's in NFHS, we have 4 visits, is better than the all India average. We have 75.8, though there's a slight decrease from NFHS-4. So that is an area of concern. But when we look at the difference or the different determinants or the different equity markers, urban, rural, of course, urban is a little better. And with schooling, it's a little more. I mean, little more means lot more, 75% and about almost 90%. Not much difference between Hindu, Muslim, and also the caste also, we don't see much difference. And there is increase in consumption of IFA, though even after increase, 180 tablets, only 30% have. And if you look at 100 tablets, I think around 60% will have has 100 tablets of IFA. So this is one area of concern, still remains even after improvement. And for ANC early registration 100 IFA, we see there's not much difference between the different, whether it is residence, schooling, religion, caste, tribe, there's not much difference that can be seen. There's some little bit 5%, 3 to 5% difference, but that is not a huge difference between different categories. Then we come to the institutional births. Very proud we are that we have increased from 75% to 91%. So this is good. And at the same time, we have also increased the cesarean section rate. And West Bengal is one of the highest in C-section rate when we go to the private sector. So there's 82.7, almost 83% of deliveries are happening in private sector by cesarean section delivery. This is something which is even more than many of the southern states. And as you know, right now, this cesarean section rate, very high, increasing cesarean section rate and increased medicalization of childbirth has made even the central government sit up, and the midwifery program has been rolled out. It has been rolled out from initially from Hyderabad, which is, they have started the training of midwives, which is as a cadre. Midwife as a cadre, which has started. It's a very ambitious program. but it will take a long time to saturate the country with midwives, because it's a long training program. First, the educators will have to be trained, and then the midwives will have to be trained. So this is a huge and very ambitious program that will take time, but simultaneously also there needs very deep introspection on, we know the reasons of cesarean section. Most of it we know. That we know about the commercial part of it. We know about the time constraint of the obstetricians. We know that sometimes it is also demanded by the client, that is the woman or the family. We know of all of that, but yet the 82%, 83% cesarean section by any kind of explanation, this is just not acceptable. So what can be done, how the societies, the obstetric societies come together, and especially how the private sector comes together. And it's high time that they start discussion, and there's some regulation which is required, how it will be done, along with the midwifery, which is one of the answers to this over medicalization of childbirth. And Janani Suraksha Yojana, as we know, only 35% receive Janani Suraksha Yojana, and it's less in urban. We know in the urban the system is very weak, so many people don't even know that this Janani Suraksha Yojana. We have also seen, this is not part of the survey, but we have also seen the Janani Shishu Suraksha Karyakram JSSK, that is there, its take is also much less. We have reduced the out-of-pocket expenditure, but so from about 8,000, which was almost, I think, the highest in West Bengal, it has come to 2,000 plus. So that is one of the one good thing which has happened. So this high increasing rates of cesarean is especially in private. Overall, also it has also reflected in overall rate 32.6, and we know that 10 to 15% more than that cesarean section, mostly it is unjustified. Coming to the postnatal care has also increased, but 68% is still not, within 48 hours is still not acceptable, because we know most of the mothers die either during delivery or in the postpartum period. So there's a no postnatal care in 26%. This is the gap which contributes to maternal and neonatal deaths, because we know most of the deaths are within the first day or within the first 48 hours. So this is also something which needs to be improved upon. Coming to the child vaccination, we have done well, and we have done much better than the national average. We are better than the national average. Full immunization is around 88%. But their full immunization among children in urban areas is less. Earlier, the gap was even more. There was 10 percentage point gap between urban and rural, which has reduced to 6 percentage point. But if we had access to data, disaggregated data, with showing the urban poor, urban rich, and this is one area where there's government facilities to have give the services most of the time. So this is one area where improvement can be done if the system can be strengthened, because in West Bengal at least there's almost no resistance to immunization. And if you look at the absolute numbers, even if we have the 88%, the remaining 12%, if you convert it into absolute numbers, it will be quite a big number of children who are not getting fully immunized. And also we know that booster doses are important. If you look at the MCV2, you will see that there's only 44%, and India is even worse. So this is also one area where we need to be careful, and we need to definitely focus upon. And if you see the vitamin A is also something, only 68%. There are issues of supply, etc. But still, vitamin A, we know that for measles and for improving survival, vitamin A has some role. So these are the two areas, and of course, urban immunization is something which we really need to strengthen. Coming to the feeding practices, so we come to another area which is a huge area of concern: feeding practices and malnutrition. So if you see the EIBF, early initiation of breastfeeding, is 60%. If we see we have discussed this so many times over and over again, that if you have a 92% institution delivery, why should your EIBF be only 60%? It has improved, but it has not improved enough. And exclusive breastfeeding, actually we have deteriorated. We are stuck. Not deteriorated, only 1% point increase from 52 to 52%. So this is also something where a huge amount of focus is needed. It's entrenched with social norm and behavior, but it is also possible to have good counseling and follow-up for improving this. And coming to complementary feeding, we are at 67.8%, and which was 52%. So we have improved, and we are slightly better than the India average. But still, that means about 30% are not receiving timely complementary feeding in 6 to 8 months of age. And lastly, coming to the adequate diet, which takes into account the timing, the quality, as well as the frequency of diet. In breastfeeding and non-breastfeeding, it's done separately, and this is for all children. I mean, the combined breastfed and non-breastfed children, which is at an abysmal 24%. That means only, and the India average can't even be, I mean, imagined. Only 11% children are getting adequate diet, and only 24% in our state are getting adequate diet, which means this is the core of one of the most important reasons. As I said, that teenage pregnancy is something and child marriage is something we are still grappling with the reasons. Nutrition, we are actually not grappling with the reasons. We know that children are not eating properly, they are not eating enough, and they are not eating timely. So we know. And the quality of the food that is also given, the way it is given, it's all wrong. I mean, in most of the places. And you will see that the adequate diet, there's not much difference between rural and urban. And if we have had the other ones, even schooling and in mothers, whether they're educated or non-educated, there's not much difference. That means this misconception about infant young child feeding practices, misconception, lack of awareness, lack of information about how to feed the baby, what to feed the baby, when to feed the baby, how frequently to feed the baby. This is something which is very much lacking. Exclusive breastfeeding, people know about it, but they do not practice it. Many people do not practice it, but maybe due to different reasons. Some, they go out for work. Some think that the child is not getting enough milk, so I need to add. Some think that these other things are better, the teen milk, etc. There are many reasons. However, but that's why they know. Many people, whoever you ask, they know that 6 months exclusive breastfeeding is required, but the complementary feeding, there's a huge lack of knowledge and awareness, and adequate diet especially. There's huge lack of knowledge. And so as you can see, NFHS-4 and 5, we have improved to some extent, both early initiation of breastfeeding, exclusive breastfeeding almost stagnant, complementary feeding we have improved. Adequate diet also a little bit we have improved from 19 to 24, but so still we are lagging behind. We and the entire country is lagging behind far. So we come to the nutritional status. We see the nutritional status here. Severe, if you look at the left one, where we are showing the nutritional status of children in West Bengal and in India, we see 33.8% are stunted, 20.3% are wasted, and 7.1% are severely wasted. That means less than 3 standard deviation. As we know, stunting means height for age, wasting means weight for height, and severely wasting means wasting which is less than 3 standard deviation. And if you see that it was 32.5, that means it has increased, or you can say it's stagnant, 32.5 to 33.8. Almost stagnant or slight increase from NFHS-4. 20.3 wasting remains 20.3, it's stagnated, and the severe wasting has increased in India, in West Bengal. So in all over the country also the picture is equally grim. So this is something which is very, very serious. And if you see that, and if you see there's now the dual challenge, overweight is also increasing in children as well as in women and adults, women and men in adults. And so sometimes we call it triple challenge, because along with it, the anemia. So if you can have children who are stunted, who grow up and then they become obese. So this is a very peculiar thing. We know that this happens. So, and they are, at risk of all kinds of non-communicable diseases. We know this is happening. It is poor and stagnated country, and severe undernutrition and stunting have increased in the state, which is a very, very serious issue. So this is also, we know the reasons to some extent, we know the reasons. But here the challenge is that what can be the response? what can be the response? Because it has to be a multi-sectoral response. It cannot be only ICDS or only health, tackling this enormous burden of malnutrition in children and adults. And equity, if you look at the equity marker, it's male, female, there's not much difference. In urban, it's little less than rural, whether it's underweight or whether it's underweight, there's a little difference, but the rest, that means wasting and stunting, there's not much difference. And as I said, male, female also, there's not much difference, but education of mothers, there's a huge difference. You see, there's a huge difference. And also in the tribals, if you see tribals, if you look at the underweight in tribals is much more. It's 10% point, whereas underweight in general overall it's 32%. You see the underweight in tribals is the tune of 44%. So educational status and nutritional status of mothers. If you see the mothers with normal BMI versus mothers with who are underweight and their children, you see that underweight is 32% in their children if she has normal BMI, and underweight is 43.6% if she has low BMI. So stunting is 32% in the child if the mother has normal BMI, and it is 42% if the mother has a low BMI. That means the chronic malnutrition. We know stunting is chronic malnutrition, and underweight is a combination of chronic and acute. So mother's nutritional status definitely impinges upon the chronic malnutrition of children. We know the intergenerational cycle of malnutrition. So this is again coming up, very clearly in the data. So educational status, nutritional status of mothers make a notable difference in stunting and underweight prevalence in children. And we know that the tribals. So the districts with tribal, in this, by the way, in this presentation, I have not brought in the district-wise disparity because that would have been another discussion, because district-wise there's a huge disparity we see in many things. Many of the indicators, excepting some of the service coverage indicators, which are not much difference, but mainly the indicators which are related to social norms, which are related to educational status, automatically depending on the district's features, there's a huge disparity, but I have not brought that in this presentation. Anemia, another area of concern, is a major public health problem in West Bengal, especially in women and children. And anemia has increased both across the country as well as in West Bengal. But in West Bengal, the increase is even more from NFHS-4 to 5, about 10% point. And this is something where I think much more research, not me only, but all the public health professionals are thinking that much more research is required. Here also, it's baffling. Why has it increased so much? I mean, nutritional status, the things are bad, they have remained bad, so there's a stagnation. It's very bad, but we can understand why it has remained like that, because the feeding has not improved, etc., and the poverty has remained, etc., etc. But why anemia has increased in our state by 10% point, this is something which everybody is grappling with. They are not understanding. So whether there are other anemias, non-iron deficiency anemia, which are contributing, and why is it showing now? Because if other anemias were there, it would have shown earlier also. We checked, there has been no change in or difference or no change in the methodology. Actually, we were so baffled, we actually contacted the Delhi people who have actually conducted the survey, UNICEF did, and we tried to find out whether there has been any change in methodology in estimation of anemia. No, there has not been any change in methodology. So why it has changed? This is very important. And it's so high that there's not much equity angle also, inequity in it. Everybody is having high anemia across. You see women, mild, moderate, severe. If you see, moderate is the highest. Of course, always mild is 30, moderate is 39% in women. Men 20, 18, and 18%. There's a difference between men and women, of course. And children, it's 36 and 50%, which is very, very high. And across, we see maybe women, pregnant women, it's a little less because they're having the IFA tablets, and we know IFA tablets intake has improved. But we also know that only IFA tablets will not be working. And The preconception care, we do not have the preconception care. We have high teenage pregnancy. No, I mean the preconception care, which is not there in any of the programs. So maybe we know that the women are entering into pregnancy with anemia, and some IFA tablets are being given, some are taken, some compliance is very variable, some take, some do not take. So there's some improvement maybe in the hemoglobin level, but again, after that, the child is born anemic and etc. etc. We know this, but why it has increased? Why it has increased so much in the last 5 years? That is something which is very baffling. So as I say, there's definitely there's a need for further research to look into this, and another area of concern which is looming large, which is non-communicable diseases. We have just started thinking about it, just started talking about it, not just now, but some, these health and wellness centers, the comprehensive primary health care approach, etc., etc. We are talking about it, but there's lots and lots to cover now. And if we see the compare with the India average, India figures, we see that in hypertension, it's more or less the same in women and men. I mean, of course, in men it's more. I'm talking about India and West Bengal. We see that in West Bengal, hypertension in men is slight. Sorry, no. Here I'm not talking about the India. Yes, India and West Bengal. Sorry, here the blood sugar level. Blood sugar level. We see that in men in West Bengal, 21% have high blood sugar, vis-a-vis 15% in all over the country average. That means diabetes. Diabetes is more prevalent in our state than the all India average, in both in men as well as in women. The hypertension, it's more or less same, and in men it's a little less than in all India average. And tobacco use, we are almost 50%, which is more than the country average. And in urban and rural, if we have a look, we see that in urban areas, it's more. It's slightly more than rural areas. So 50% are having smoking, and 20% are having high blood pressure, and 21% are men and are having high blood sugar. That's where we are. And screening of common cancers in women, it's only 0.1% women, and only 5.5% men are screened for common cancers for women and men. So this is also one huge gap area, where we are staring, and maybe the NFHS-6 will show even a worse picture if we do not have very robust programs as well as lifestyle change endeavors and initiatives, which is again entrenched in our behavior and norms, eating habits, etc., which is very, very difficult to control. Women's empowerment, this is also something we know. We think that maybe women in West Bengal are empowered. They are very articulate mostly. That's why I'm saying that sometimes we are perplexed when we go and talk to the adolescent girls and the women. They're so smart, and they are much more. Sometimes the adolescent girls are much more enthusiastic, active, eager to learn than the boys. Yes, women empowerment, if you look at some fundamental issues, we are very much lagging behind. Look at women who worked and got paid in cash in the last 24 months. It's only 20% in West Bengal, even worse than all India average, which is 20%, which itself is low. Owning a house or land, that means poverty. In women, only 23% they do that. So these are two areas where it has remained low. Now the bank account is much improved, much more. It has improved, maybe because different schemes which are directly transferring money to their women's accounts. So that has improved. It's 76% now, which is good. And mobile phone also 50%, half of the women have. And decision making also they do participate quite well in the decision making. And if you see at whether there's a access to money, whether there's a difference, yes, we see rural, it's much less. They have access to money. If they are more educated, definitely they have more access. If they're employed, they have more access, and Hindu women have more access than Muslim women. And in decision making also, we see Hindu women have some more little more than Muslims. In nuclear family, they have more, they can say more, etc. So this is also slight differences there. Gender-based violence, we see that about 30%, 27%, and in all India 30% are women, ever married women, who have experienced spousal violence. So even in our state, it's 27%. So when we are talking of women empowerment, this is something which is absolutely unacceptable. And also violence during pregnancy is there, 3%, etc. So, and in rural area, it's more, 28% vis-a-vis 23% in urban areas. And during pregnancy violence, you can see 18 to 19 years, it's about 10% of women. Oh, I mean, overall, it's 3% or 3.5%. But when there's young girls who are getting married, they have experience of violence during pregnancy. So the spousal violence is almost 30%, which is very, very serious. And that reflects the, disempowered women, womanhood in our country as well as in our state. And what kind of, mainly it's slapping, which is, about 16%, which is slapping. And if you look at the NFHS report, you will see that many women also think that it's okay if they don't obey they show disrespect to the in-laws, etc. It's okay that they are slapped, etc. It's there. And also, in the we see that it's maximum 67.3% in divorce, or who get the violence, who face violence, divorced or separated, they get violence. And if you don't have schooling, more chance. If you're a rural woman, you are more have more chance for gender-based violence. Hindu Muslim here, it's almost the same. So that's also a myth that we need to break. And in nuclear family, because maybe they are alone, they are are more vulnerable to violence by their spouses. So by this, come to the conclusion that we know, and we reiterate that health is much beyond health sector. We know in community medicine, when we started the first chapter, that is what we have read, but most of us, I'm not talking of community medicine people only, but most of us doctors and healthcare workers, we forget this. Poverty, lack of education, and women's empowerment are the underlying factors for many deprivations in children and women. We reiterate, and every year, NFHS-5 is bringing it, but as the service coverage is improving, because there are things which are happening in the health sector in different grades. In some states, it's happening faster, in some states, it's happening slower, but in some improvement is happening. There is still a lot to be improved, but coverage services is improving, we know. But these are, certain basic things which are still, lacking, which needs to be much more if we have to, actually go into those issues which do not depend too much on service delivery, but depend on behavior, on day-to-day practices, on social norms, etc., on empowerment of women, etc. And specifically for the nutrition, a lot more focus, clarity, and multi-sectoral action and accountability are needed in the area of nutrition, including anemia. You believe me, we have had, series of discussion with top-level people, but ultimately that multi-sectoral action where everybody will have different stakeholders will have to be involved. That somehow doesn't come through. These are not, it never becomes the highest political agenda. That nutrition and anemia has never become the agenda of any political party ever. So, but that has to come in. Unless that comes in, because it is not really visible. It's not hospitals, it's not medical colleges. So unless it's visible, it can never be, that's why it's not, attractive enough. But this needs to be really tackled. As I say, child marriage is complex and adolescent issues really need special and urgent attention by stakeholders, not only because of pregnancy, but adolescence, the entire, that adolescent issues really need to be talked about and talked about openly. And teenage pregnancy, child marriage is something which we usually do not talk very openly. That what are the root causes? We need to understand more. And teenage pregnancy can be tackled with well thought out strategies as an entry point, because child marriage is very difficult to tackle. But yes, we also have to. Apart from quality of RMNCH services, attention towards non-communicable disease, as I said, much needed, and to some extent just started, but a lot has to happen. Urban indicators need further analysis and disaggregation. We have not yet got the unit level data, because that is not available right now, but I'm sure when the urban is unpacked even further, we will see how the slums are doing, how the urban poor are doing. That when we look into a little deeper, we'll see that they are doing, sometimes they are doing even worse than the rural poor. Inter-district variations, which I have not shown here, they also need a focused attention. And of course, we have to again go back again and again to primary healthcare, its universalization. And so I hope I am on time. Thank you very much for giving me a patient hearing. But of course, I don't know whether in the online things, whether it's patient or not, you can always mute yourself and not hear. If you can hear if you wish to. Thank you. Thank you.
Thank you, madam, for the very wonderful session. And I am now requesting Professor Nirmal Kumar Mandal sir to make the concluding remarks.
I want to express my sincere thanks to Dr. Konika Mitra for his nice, attractive, and lucid presentation. She has tried to highlight the different areas after analysis, some areas of strength of us, like increased immunization, institutional delivery, and also reduction of IMR, etc. And at the same time, he also raised some important issues of concern, and that are related to some behavioral aspects and social aspects, and like child marriage, teenage pregnancy, girls insecurity, poverty, increased level of the cesarean sections in emerging non-communicable disease like this. So I want to again thanks Dr. Mitra, because in spite of her hectic schedule, she has taken time to come here and to give this important information. And to the audience, I can request our members that we can take up this area of concern. If we are interested to work on it, we can do it individually or in collaboration with some agency. That this area of concern is the concern of community medicine also. So as a body of IFSM, as well as individually, we can work on these important issues. Otherwise, it is a collaborative effort. Otherwise, we cannot reach our goal. And because it's a very important findings which we have, that still, in spite of the different efforts, we cannot meet our target yet. Thank you, Koindika. And as it is the last session, so I want to extremely thank to Professor Jadhav Chandra, Professor Jadhav Sardar, Dr. Divu and his team, all conveners, so nicely managing all the things. And this time, I think our conference, which was restricted to state level, later national level, now it has reached to some extent the international level of conference. Thank you so much.
Thank you, sir, for closing the session. So we come to the end of a marathon 2 days of online session, and thank you for bearing with us. We discussed about many things under the sun in public health, and so we can start the valedictory session and close it fast, because maybe all of you are very tired. So Jadhav sir, there is some problem with his audio. So Indira madam is there. So I shall request Indira madam to come, and I shall present the conference report very shortly, in a very short manner, and ask Indira madam to close the session on behalf of Jadhav sir. So I am presenting the conference report. Am I visible, Dr. Shatabdi?
Yes, please.
Okay. So as the organizing secretary, we did this conference on 2 days, 3rd and 4th of December 2021, and it was done by the Department of Community Medicine, Ajikor Medical College. So in day 1, the sessions were stopping the way to a dusty death. It's now or never on occupational health or diagnosing silicosis, diabetes in young, a public health challenge, where two speakers talked about type 1 diabetes, COVID pandemic, the way forward, where we had an international exposure, and also our own Kunal sir said about the Indian perspective. On day 2, we had sessions like innovations in malaria control, where Dr. Kaushik, who is working with artificial intelligence, shared his experiences. For NTP session, we had the chairman of NTF, Professor Ashok Bharadwaj, and Dr. Qazi Tawfiq discussing about the NTP challenges and what can be done. For Immunization Agenda 2030, we had Dr. Rita Setki, who is the founder of the Geneva Learning Foundation, who discussed about many interesting ideas and proposed us to collaborate with him. The very exciting session was CBME curriculum, past, present, and future, the talk of the day for us medical teachers, in which we had 4 eminent speakers discussing about the various aspects of CBME curriculum. Next, we had a session on neglected tropical disease, where we had Dr. Raman Velayudan from WHO, Geneva, and Dr. Pritam Rai from India, who talked about the tropical diseases in the global scenario, strategic planning, and also in the Indian scenario. We also had the NFHS-5, which has just ended by Dr. Kunika Mitra, who is an UNICEF specialist. So these were the scientific sessions. Also, we had a very interactive session by the career opportunities in public health, moderated by Dr. Ochishman Mohapatra, the director of Grid Council. We had experiences shared by faculties from AIMS New Delhi. We had people from Johns Hopkins University and from all over the world who shared how to build your career in public health. Regarding the award sessions, we had 3 award sessions: IIPSM grant for best research project initiated by Professor Apalanko Bhandari, Professor M.M. Ganguly Memorial Award for Young Scientists, and Professor Ranadev Bishwas Memorial Award for Best Poster Presentation. I am just thanking the judges who made the initial decisions. For M.M. Ganguly presentation, it was done by Professor Romi Bishwas, Professor Prashant Roy Kormakar, and Professor Divakar Haldar. So thank you for that. For the preliminary screening for the best research proposal, it was done by Professor Nirmal Kumar Mondor, Professor Palas Das, and Dr. Obik Sinha. So thank you for that screening. And my sincere most thanks goes to the nodal persons, all the nodal persons who have been working very hard for the registration process in this pandemic scenario, the moderators of all the sessions who have worked wonderfully coordinating with the speakers and the event management company, the souvenir committee, who will be bringing out the souvenir very soon with the reports of this conference, and also the abstracts and some non-scientific writing by our members, which are of their COVID experiences. We also want to thank the EC of IBSM West Bengal chapter and also the IBSM national body. We all want to thank the staffs and principal of Ajikar Medical College, and we also want to thank all the delegates for bearing with us. And obviously, we want to thank LearnNet, their wonderful team of Ishika, Nishita, and Enaki have helped us and answered all our queries throughout, though there was an initial glitch. So also the winners of the all the sessions have already been announced, and I want to congratulate all of them. You have done a wonderful work, but I also want to say that those who have not won, they have also done a wonderful work, but we had to choose some winners. That is why these names are given. So keep on working in this manner. So thanking all of you, I want to stop this report, and I hand over to Dr. Indira Depal to say the closing remarks and close the scientific session. Madam, please.
Everybody, am I audible?
Yes, madam, you're audible.
Hello? Okay. Okay. Good evening to all of you. I'm really happy to conduct this conference online, and for that I'm thankful to our organizing chairperson and organizing secretary and the Department of Community Medicine of Ajikar Medical College for conducting such a marathon 2 days conference. I find that this online conference have some advantages as well. Like we can shoot in when we want. We can do it from our working place. So only that we could not discuss things face to face.
Madam, your audio has gone.
Even we had speakers from international level. So I find that not only this online conference is not only having disadvantages, it's also advantageous to some extent. Secondly, coming to the sessions, in the actions, we find participation from the PGTs. They have shown their enthusiasm. The speakers, I'm thankful to all the speakers who have taken great interest and have presented very well. And they have also cooperated with all of us. I'm also thankful to the moderators, the young generation. They have come cooperated nicely and conducted the sessions, as well as the seniors.